Good. Yes, sir. Okay. All right, good afternoon, everyone. Welcome to Medicine Grand Rounds. I hope everyone had a fantastic Memorial Day weekend. I know it was wet for those of us that stayed here, but as I was telling a few folks, I got a lot of Jenga time in with my family. So I hope you had some time with your families as well. A couple of announcements. Next week, we look forward to welcoming Dr. Benjamin Levin from UT Southwestern. Dr. Levin will be delivering our annual Blount lectureship entitled Exercise and Cardiovascular Health, How Much Exercise for What Benefit or Harm. I'm sure that's a topic we will all be excited to hear about. And on June 11th, we will welcome Dr. Utibe Essien from UCLA for Grand Rounds, and he will be talking about pharmacoequity, which is a term that he coined, and making that case for atrial fibrillation, which will also be a fantastic talk. Today, it's my pleasure to introduce our inaugural James G. Hakeem Lectureship speaker, Professor Gift Wilson Ngwende. First, let me tell you a little bit about this new lectureship in the Department of Medicine. The James G. Hakeem Lectureship was created thanks to sponsorship from the Zimbabwe AIDS Treatment Assistant Project, also known as ZADA. For those of you who come to my office, you'll see there's a lovely painting on the wall that actually comes from Zimbabwe that was gifted to the department from the ZADA leadership. The lectureship honors James Hakeem, the past chair of the Department of Medicine at the University of Zimbabwe, who was also an adjunct professor here in the Department of Medicine and the University of Colorado. I never had the privilege of meeting James. He passed during COVID. But I will tell you, if you look him up and read about him, you'll see that he was an acclaimed investigator. He was a professor of professors and a profoundly important leader in advancing medical research and education, not just in Zimbabwe, but in all of Africa. He was a scientific giant in the HIV community. He was instrumental in putting HIV research and science in sub-Saharan Africa. And he drove studies that had not only regional impact, but also global relevance and global impact in how we think about that disease on that continent. I will also say, for those that know him, I've heard he was a humble and respected person, both in the medical and patient communities. It is an honor today then to inaugurate the James G. Hakeem Lectureship. Thank you, Zada, for the continued support. And it's a delight to have Dr. Ngwende here as our inaugural speaker, all the way from Zimbabwe. Let me tell you a little bit about Professor Gift Ngwende. Dr. Ngwende is a consultant neurologist and senior lecturer. He's also chair of the Department of Medicine at the University of Zimbabwe College of Health Sciences. He directs the Epilepsy and Neurology Clinic at Parirendyatwa Hospital in Harare, the only neurology clinic in the country. In 2013, he established the first and only stroke unit in Zimbabwe. And until 2016, he was the only neurologist working in the entire nation of Zimbabwe. He has since been joined by two other neurologists at the University of Zimbabwe. It's not surprising then that he has multiple leadership roles. Since 2021, Professor Ngwende has served as a scientific area lead on a 5-year NIH grant to train a critical mass of early career investigators. He's focused his expertise on mentorship and growing physician scientists in stroke and neurological diseases. He's the current president of the Zimbabwe League Against Epilepsy, a member of the Zimbabwe Epilepsy Support Foundation Management Board, and the lead writer for the National Epilepsy Treatment Guidelines for the Essential Drug List in Zimbabwe. Professor Ngwende is a fellow of the Royal College of Physicians in London. He's also on the European Board of Neurology, and he comes to us with extensive expertise in internal medicine, neurology, medical education, and of course, mentorship. It's a true honor for me, Professor, to welcome you here today. Please join me in welcoming our 2025 Cozy Lectureship, Stroke Care in a Low-Income Country, Setting Up and Rolling Out Low-Cost Stroke Care Units. Professor Ngwende.
So thank you very much, Dr. Chopra, for that very kind introduction. I'm absolutely delighted to be here this afternoon, and I'm humbled to stand on this stage. When I was asked to deliver this talk, I asked Tom Campbell and says, can you send me a few slides and so that I can have a look and see what actually happens? and I saw the illustrious speakers who have stood on this particular stage and delivered amazing talks. And this afternoon, I'm going to speak on something that is probably not as high-tech as the usual talks that you get here, but I think something that's worth sharing and something that's worth discussing. So the topic of my presentation this afternoon is stroke care in a low-income country and setting up and rolling out low-cost stroke units in Zimbabwe. And the presentation that I'm going to give, I'm giving it on behalf of a number of people, consortium of universities in Zimbabwe that I'll probably mention at some stage, and also the Clinical Collaborative Research Center in Zimbabwe and the 4 stroke units that we now subsequently have in Zimbabwe. So it's my honor to present on their behalf. Now, the learning objectives today is to figure out how to develop cost-effective strategies for low-cost stroke care units setup, and how this implementation is driven by evidence-based stroke care protocols, and how it is necessary to establish partnerships to ensure sustainability. I had the honor of and privilege of touring your various units today and your stroke service. It's amazing. It blew my mind off. And I wondered, should I actually be giving a talk on stroke in this environment, or I should just pack my bags and go home? But now that I'm here, I'll share my experiences. I have no conflict of interest on today's presentation. And as Professor Chopra has mentioned, I'm dedicating this particular presentation to James Hakim, who was my former chair of the department, and towards the end of his life, he was the professorial chair for the Department of Medicine, a great mentor, and he had a drive towards academic excellence and research, and personally mentored me. And I now have the huge burden of occupying his former office. So that former office, those of you who have been to Harare, I somehow ended up in that particular office. So it is my honor to present this talk and dedicate it to Professor James Hakim. Now, I'll just start with a little clinical vignette. Now, this particular case is from my old archives, and it's very common across Zimbabwe. A 55-year-old farmer who presents with severe sudden onset right-sided weakness about 16 hours before presentation. He has got word-finding difficulties. He can't comprehend speech and conversations. He's hypertensive, he's diabetic. He is on treatment, but we're not so sure about the level of control of these 2 comorbidities. He's then attended in our emergency department by the medical intern, the registrar, who is equivalent to your residence here, who makes a diagnosis of a total anterior circulation stroke and admits him in the medical ward. So that was the standard of care, where he's managed by the internal medicine team using whatever guidelines they were using. But unfortunately, over the next 4 days, he deteriorates neurologically, and we lost him on day 4. Now, this case is such a common scenario where I come from, but not just in Zimbabwe, but right across sub-Saharan Africa. And you could argue and say, was this patient going to end up with this outcome if they were being managed at, say, UC Denver? The answer is probably yes, that could still happen. You can still have this outcome, but the chance of this happening would have been far less here than in my environment. Now, I'll talk a little bit about stroke and stroke care right across the world. Worldwide, and between 1990 and 2010, there was an increase in stroke-related deaths of up to about 26%, and equally, there was an increase of about 19% in terms of disability-adjusted life years. And stroke is the 2nd leading cause of death after ischemic heart disease, we know that, and the 3rd leading contributor to disability-adjusted life years. Now, what's interesting is that a lot of this burden is in the low to medium income countries. So 70% and 87% of strokes and stroke-related deaths and disability-adjusted life years occurs in the low to medium income countries. So the countries that have got the biggest burden of stroke mortality and stroke morbidity have got the least capacity to handle this particular condition. And we have to try and figure out the best way of addressing this. Now, one of the major problems that happened as when we had the HIV epidemic, all these conditions, non-communicable diseases, were set aside and a lot of efforts, funding, and resources were channeled towards AIDS and HIV programs, as well as TB and malaria. That's where the money went, and this was set aside. So despite the fact that stroke has got such a huge impact on economies, especially where I come from, where we tend to get younger strokes and patients who are at the height of their productive lives, they are the ones who are getting strokes. And that has got a huge impact on the economies in these particular countries. Now, again, this is just a map that shows the global disparities and variations in stroke burden and mortality. And if you look at it and look at the colors don't really come out very well there. But if you looked at it, you look at Zimbabwe, it's somewhere in the about 101 to 125 stroke mortality per 100,000. And that is pretty high compared to about 24 to 50 in the United States and elsewhere. Now, if you do a review of the literature, you looked at the literature on stroke mortality in Africa, it makes sad reading. You look at those figures that our stroke mortality is anywhere between 20 to about 57%. Now, a lot of these studies have got the methodological difference. It's very difficult to do a head-to-head comparison. But in general, if you looked at a lot of these studies, which were hospital-based, and you look at countries like Gambia, where at that time, in about early 1991, they had a case fatality rate of 57%. That's more than half your patients that you admit. And that is quite scary. And over the years, you may notice that there might have been a secular trend. As stroke care improved right across the world, the figure started coming down to about 23, 30%. In Zimbabwe in particular, there was a community-based study by Professor Jonathan Matenga, and that reviewed a 35% one-week case fatality rate. And closer home, our neighbor Zambia, it was 40%, 50% early on, then it came down to about 40%. Now, compare and contrast that with, I just selected one particular country, that's Canada, and you look at the stroke mortality in a selected high-income country, and Canada is supposed to have one of the best stroke care programs in the world. You look at their 7-day case fatality rate. This was just for ischemic strokes. They did not include hemorrhagic strokes. It's 6.9%. So that's quite low, and you compare that with the figures from the African continent. You look at the 30-day case fatality rate, 12.6%, and at 1 year, they had a case fatality rate of 23.6%. Now, I like this particular slide here. Those who have been to Harare might recognize one of those chaps, Professor Jonathan Matenga. And I attended a meeting in Zambia, and I came across the gentleman on the right, on the left. That's Professor Richard Walker. And he's done a lot of research and published extensively on stroke in Africa. And I introduced myself and say, hey, I'm from Zimbabwe, I do stroke work. And Richard Walker said, oh, when I was doing my thesis, I quoted some studies from a gentleman called Jonathan Matenga. Is he still alive? And I said, yes, he's alive. In fact, he's at this conference. So I then went and dragged Jonathan and introduced him to Richard Walker. So I was privileged to see people who have done a lot of stroke work on the African continent. Now, what stroke interventions are there? Now, this list is not exhaustive, but I just wanted to touch on these interventions and demonstrate what can be done and what can be done in a low or a resource-constrained environment. If you look at aspirin in 1978, introduced in 1978 for ischemic strokes and transient ischemic attacks, and it demonstrated that you could get a reduction in early recurrent strokes with a number needed to treat of 83. Now, we can do that. We can give aspirin. There's aspirin virtually in every little shop in Zimbabwe, so we can deliver that. But look at the number needed to treat. Carotid endarterectomy after the North American symptomatic carotid endarterectomy trial, it was proven that it's actually useful for patients with severe carotid artery stenosis, and it leads to a reduction in embolic events. Most African countries cannot offer this particular service, so this is not an option. Warfarin therapy introduced in patients with non-rheumatic atrial fibrillation, 1993. I was just starting my medical school training at that stage. It demonstrated a reduction in thromboembolic events. We can give warfarin. The problem with warfarin, again, in a low resource setting is monitoring. You need to monitor your patients, and they need regular INR. Clopidogrel introduced in 1996, used for TIAs and now used routinely as dual antiplatelet therapy for the first 21 days. Patients have had transient ischemic attacks. It's not available in most public, sector hospitals. So it is an option, but the medication is not available. Thrombolysis, this was the big one with TPA 1995. After the National Institute of Neurological Disorders and Stroke, and subsequently refined by the European Cooperative Acute Stroke Study that extended the therapeutic window to about 4.5 hours. It demonstrated impressive results. Number needed to treat 8. We can't offer that. Our patients present very late to hospital. The thrombolytic agents are very expensive. I was talking to somebody this morning and said tenecteplase will cost about $900 United States dollars paid out of pocket. So this is not an option. And the infrastructure that you need around this service requires a lot of money. Then of course, hemicraniotomy, 2007, there were a lot of 3 little studies, Hamlet, Desmo, and Destiny, 93 patients. But they did demonstrate that, in fact, if you can offer hemicraniotomy early in patients with malignant middle cerebral artery territory, space occupying edema, you could actually reduce mortality and improve functional outcomes in appropriate patients. Now, our neurosurgeons can do this. They are often reluctant to do it for one reason or the other, but they can actually do this. Mechanical clot retrieval, again, I had the privilege of taking a tour around. And there's so many studies that were done that demonstrated that, in fact, it leads to improved outcomes and is used in ischemic strokes in patients with large artery occlusion. The infrastructure that's required it's not available in the low to medium income countries. And more recently, we've had the stroke care bundle in the INTRACT 3 study, which basically showed that if you use the so-called stroke care bundle, where you are trying to maintain normal glycemia, maintain systolic blood pressure between 130 and 140, reverse anticoagulation early within an hour of admitting that patient, and keep the temperature below 37.5 degrees Celsius. My apologies, I will use degrees Celsius, that's what we use. That actually leads to improved outcomes. There's a mortality benefit and you get better functional outcomes. We can do that. The ENRICH study for patients with intracerebral hemorrhages again demonstrated that in specific patients with supratentorial lobar hemorrhages, if you use minimal invasive surgery, that actually leads to improved mortality, you get better functional outcomes. We can't do that. So when you look at this table, a lot of the advances in stroke care that are accessible and available to your patients are not routinely available to my patients. So what do? So we decided we would go to, we decided to say, let's go back to an old intervention, stroke units. These were first muted in the 70s, and they gained traction, lost traction. There are various models that were tried, but in fact, it's now very clear that they're suitable for all stroke types. So if you look at those interventions, you realize that in fact, stroke care units are suitable for all stroke types. They lead to a mortality reduction. They lead to an improvement in functional independence. Now, when somebody gets a stroke, the concern is not whether you're going to die or not. A lot of us are worried about whether we're going to become functionally dependent and lose independence. And so stroke care units have been found to improve functional outcomes. You're more likely to be independent at any point. And they also lead to reduced hospital stay. The fear has always been, doesn't that increase hospital stay? But in fact, it has been demonstrated that they actually reduce hospital stay. And they lead to reduced need for institutionalization for patients. The number needed to treat is 25. Now, how do you set up these stroke units? At a very basic level, they require reorganization of existing hospital beds. It's moving the beds around within the same hospital. And a stroke unit is basically defined as a unique, identified geographical, physical space within a hospital where all patients with a stroke are managed by a multidisciplinary team of stroke experts. They require very little or no funding. They depend on multidisciplinary care. They use a protocol, a standardized stroke protocol, and their patients tend to mobilize early. They've got better access to rehabilitation, and they've got very specific endpoints. saying to somebody that the reason why people used to be discharged in my hospital before he set up stroke units is because the service just needed the bed, and say, well, he has been here for 2 weeks, we need the bed for another patient, send him home. There were no specific endpoints why these patients were discharged. But more importantly, it also leads to an expertise, it increases expertise in the health professionals who are looking after that particular unit. I like this chart. It's an old slide that I've had. It's from 2003 from Australia. That basically tries to demonstrate the unique benefits of a stroke unit compared, for example, with aspirin and thrombolysis. And in this particular slide, the important thing is to realize that when they did this study in Australia, there was very little uptake in terms of these interventions. 23% of their patients had access to stroke unit care. 70% of their patients received aspirin within 48 hours of admission, and thrombolysis was only done in less than 1%. So less than 1% of their patients had access to thrombolysis. And then they hypothesized that if we basically increased and maximized adoption of these interventions and increased stroke care unit admission to about 80%, ensure that 80% of your patients get aspirin within 48 hours of admission with an ischemic stroke, and increase stroke thrombolysis by 10%, up to 10% of patients. And if you look at that last column that compares the absolute benefits of these interventions, you realize that stroke care unit has got the largest benefit in terms of absolute benefits compared to aspirin and tissue plasminogen activator or thrombolysis. Now, we have this evidence. We know stroke units work. So how come there are very few in the areas that need them most? Why do they not exist in Africa? When we set up our stroke unit many years ago, there were very few stroke units, and I'm glad to say that we're beginning to see adoption of low-cost stroke units in Africa. And Professor Alan Breyer from the University of Cape Town, who I had the privilege of attaching myself, I had an attachment with him when we were setting up the stroke unit in Zimbabwe. He basically published the requirements for stroke units and the various models, from the very minimal cost stroke units that cost you very little money to the more sophisticated one. But despite this information being available, there's been very little appetite to use stroke units to improve stroke care. Now, there's a perceived lack of capacity, and that's true. There are very few neurologists in Africa. I think they quote figures of 0.3% per million population. That practically means outside South Africa and perhaps Northern Africa, there are very few neurologists. So if you're going to set up a system that depends on neurology care, it's probably not going to work. And the material resources that are required, I mean, I saw your center, we wouldn't be able to afford that. Now, when you read the literature and you look at the minimum requirements to set up a proper stroke unit in the Western literature, the figures are intimidating. You just give up. You look at the American guidelines, you need to be accredited, certified. You just give up and say, no, we can't do this. And then, of course, we don't have consistent neuroimaging. So we say, how do we image the patients? But the question is, does imaging make a difference if you don't offer thrombolysis? So that's a key question. Now, so what did we do? So we were very fortunate, and I was very fortunate to be involved, that in 2010, Professor James Hakim and colleagues in this room and elsewhere, they were the recipients of an NIH PEPFAR grant that was meant to improve medical education in these 10 countries in the sub-Saharan medical schools. And the main grant was that medical education initiative or training initiative known as MEPI. And there was a smaller linked award called the CRIS initiative, and that stands for Cerebrovascular Heart Failure and Rheumatic Heart Disease Intervention Strategy. And I was involved in the cerebrovascular arm and another colleague. And the main objective of the CRIS grant was to provide highly motivated undergraduates and postgraduate students with knowledge and skills necessary to become academic physicians and future faculty in PEPFAR-focused disease like cardiovascular disease. And overall, in this particular program, 52 fellows underwent training in this program. Some of them have visited Denver. In fact, a lot of them have been to UC Denver. And some of them have become brilliant interventional cardiologists, pulmonologists, and stroke specialists. Now, we didn't actually have information about stroke in Zimbabwe and our outcomes. And so what we decided to do was to set up a stroke registry because we didn't know what was actually going on. And one of the questions that we wanted to answer was, what is the first week mortality and functional outcomes of first ever lifetime strokes admitted in our hospital? Of course, we also wanted to use the registry to enhance the skills of these neurovascular fellows in the assessment of strokes, to develop data-driven clinical programs to improve stroke outcomes, and that's where the stroke units came in. Also to use the registry as substrate for scholarly projects and publications, and also to try and improve the quality and efficiency of stroke care. So one of the fellows, Andrew, who was doing his MEd training, equivalent to your residence program, set up what we call the CRIS Stroke Registry. And this is the profile of that particular registry. And in that period, there were 10,800 admissions onto the medical service. And out of that, 415 of those were diagnosed as stroke, and that accounts for about 4% of the total admissions. And having excluded repeat strokes and stroke mimics, he was left with 251 first-time ever strokes. And then he analyzed that information. And the first thing was that when you look at the mean age for the population, it's a younger population with a mean age of about 61 years. And that's younger than the Western cohorts, where you see patients 72 to 75 years as the mean age. The second thing was, as anywhere across the world, hypertension was the most common risk factor for stroke in this population. 19.1% of the stroke patients admitted during that period were HIV positive, so quite significant. And I want you to look at that last column about the time to hospital admission. The median is about 24 hours. So patients take a lot of time before they come to hospital. And that includes patients who live very close to the hospital. And it's because there's so many beliefs about strokes. So people say, well, he had a stroke 12 hours ago and we waited to see what would happen. Perhaps he would actually get better. They try other means of treating the patient. So the median duration before somebody pitches up at our hospital is 24 hours. And you can tell already that thrombolysis would be a nightmare if your patients are pitching up a day later. Those with hemorrhagic strokes tended to appear at the hospital much earlier because it's more dramatic in its presentation and more catastrophic. Now, during that period when Dr. Mataruse looked at this information, out of those 251 patients, there were 62 deaths during that period. And that gave us a 7-day case fatality rate of 24.7%. So you can add that figure on that table that I showed you on stroke mortality in Africa, that we are sitting at about 24.7%. So that's similar to Malawi and probably Tanzania as well. A lot of the patients that we admitted were quite sick. If you look at the modified Rankin score, it's anywhere between 3 and 5 during that period. Now, these were some of the in-hospital complications that were associated with stroke death. Pneumonia was the big one, followed by worsening stroke symptoms. That was the other big one. And in a univariate logistic regression, the significant ones were pneumonia. And this is aspiration pneumonia, and then worsening stroke symptoms. So if you look at this table, the vast majority of our patients were not dying from neurological deterioration. That was number 2. The leading cause was aspiration pneumonia. As Professor Matenga put it, says our patients are dying from choking, and we should do something about that to prevent patients dying from aspiration pneumonia. So the conclusions after we had established the Paranetrical Stroke Registry was, number 1, our case fatality rate for 1 week at 1 week was 24.7. And that's similar to a lot of the African cohorts. The commonest cause of death were aspiration pneumonia, 46.8% of our patients. So half the patients that we're losing was because of aspiration pneumonia. And of course, progression of stroke symptoms accounted for 33.9% of the deaths. And therefore, his recommendations was that we needed to reorganize our acute stroke services in Zimbabwe through the establishment of organized or dedicated stroke units. And we had to figure out the model that would actually fit our resource-constrained setting. And these organized stroke units had to be guided by evidence-based stroke management protocols. And of course, we also need to raise community awareness through awareness programs. As you can see, patients are presenting very late to the hospitals. So we decided we're going to do it. So I traveled to University of Cape Town. We were supposed to come to UC Denver, but that plan was changed. And so we ended up at Groote Schuur Hospital in Cape Town with Professor Alan Breyer to observe and establish stroke unit. And when I got there, I was looking for the sort of high-tech things that I saw this morning. I didn't see any of that. They had 6 beds. And Prof. Alan Breyer says, oh, this is the stroke unit. And I said, where? And he says, this place, 6 beds, 2 of them had monitors, and that was the stroke unit. So I spent some time there seeing how they do things. And then after that, we came back to the hospital, highly motivated, fired up, wanted to do this thing. It wasn't easy because there's always competition for space. So the first thing is when I said I needed this space, the hospital administration said, no, we don't have space. And I said, no, I'm not looking for new space. The very same square meters that are occupying, I just need to move all the beds into one corner and call that a dedicated stroke unit. And they said, that's okay. Then the principal nursing officer says, look, I don't have enough staff. I don't have enough nurses. I said, I'm not looking for new nurses. We'll train the current nurses who are nursing the patients that we have. And she said, it's okay. Then the next thing is, I don't have enough beds and linen. I said, I'm not looking for new linen. They will use the same linen that they're using right now. So when you tell administrators things that cost nothing, they normally allow you to do that. So I eventually got my dedicated 8 beds. So we now have an 8-bedded stroke unit that was set up, and some of you have been to Harare, might have actually gone through that. We did develop a stroke protocol, and we got a lot of assistance from partners. University of Cape Town and Stanford University assisted us in coming up with a protocol that would actually meet our needs as a resource-constrained environment. And then there was training that came through. We trained the physicians, we trained the nurses on this particular stroke protocol. The original team comprised of the stroke physician. There were stroke registrars, equivalent to your residents. There were stroke interns, junior doctors were trained. There was a stroke nursing team. We were able to train 30 nurses. We had a very supportive matron, principal matron. We had a sister in charge. I'll talk a little bit about that sister in charge. And then, of course, we had dedicated registered nurses. We had 2 dedicated physiotherapists. So that was the team. Nowhere near what you'd actually find here. You've got massive human resources. And so on the 12th of November, 2013, we set up our stroke unit. That's me there with that white lab coat when I was younger. And that is our sister in charge, Charity. And this is Mike from Stanford, a neurovascular fellow from Stanford, who actually was part of the team that assisted us. That's Professor Jonathan Matenga in that corner. That's Andrew Mataruse, who basically ran the CRIS registry that gave us that 24.7%. And we admitted our first patient on the 12th of November, 2013. With Nirali Vora from Stanford, she was also quite useful in coming up with that stroke protocol and refining it. 6 months later, we became curious after establishing the stroke unit. Are we doing any good? We're doing more harm. And this was the initial analysis, an interim analysis at about 6 months after we opened the unit. So by April, we said, look, we've admitted about 1 or 2 patients. Let's look and see what's happening. There are significantly fewer patients who died during that period, over 6 months. And we looked at our 1-week stroke case fatality rate. It was now down from 24.7% to an impressive 7.8%. And out of those 8 deaths that we had, only 2 resulted from aspiration pneumonia. And we had managed to set up this Parerenya 12 hospital stroke unit without increased cost to the hospital by simply reorganizing the existing beds and using practical bedside tools. And we think the biggest contributor was the swallow test, where we performed a swallow test as a standard on all patients, and that led to a reduction in aspiration pneumonia and eventually a reduction in mortality. Now, we kept looking at this data over the years, and in 2015, we said, look, we've got 446 patients. Let's see what has actually happened. Have we sustained that 7.8%? And we had a 1-week case fatality rate of 7.9%. We now had data for a 28-day case fatality rate, which is what the World Health Organization tends to use, a 28-day case fatality rate at 13.18. Remember the Canadian figure, 12.6%. We were very close to that. In 2018, just before COVID, we said, we've got 1,000. 1,000 sounds cool. Let's look at our information again. The case fatality rate was down to 7.2%, and the 28-day case fatality rate was now sitting at 0.1%. I think as we got more experience, we're able to do more on that particular stroke unit. Now, we then had the courage to inform the government that we're doing well. So we invited the Minister of Health. So the gentleman in the center with a gray suit, that is the Minister of Health, Dr. David Parirenyatwa, and our hospital is named after his father. His father was the first Black trained physician in Zimbabwe, and unfortunately passed away in August of 1962. But that's his son, was now the Minister of Health. He came to tour our little stroke unit. Our matron was there, the lady in gray, and that's Charity. The gentleman behind the matron is the Chief Executive Officer of the hospital at that time. And I also got a journalist. So the young lady between the minister and myself is the journalist, because we wanted to publicize this. And after the minister had toured this facility, he then decided that every hospital in Zimbabwe that admits more than 100 patients with stroke, they needed to use the stroke unit model. So we were able to influence policy at that stage. And I want you to go back and look at this data now from subsequent stroke units that had been set on the African continent. So in South Africa, early on in 2009, De Villiers and colleagues had demonstrated that at a district hospital that did not have a CT scan, so there was no neuroimaging. When they instituted a very simple protocol-based stroke protocol, they were able to reduce case fatality rates from 33% down to 16%. And then more recently in 2019, Guinea and Conakry, they were able to demonstrate that the establishment of very simple minimal cost stroke unit was able to reduce case fatality rate from 22% to about 72%. They had less medical complications, and in particular pneumonia, because aspiration pneumonia seems to be a major driver. Again, I'll remind you about the Canadian figures that we seem to be getting there with very little investment. Just a stroke unit, geographically defined area that uses a standardized stroke protocol. There's no thrombolysis in these particular units. There's no mechanical clot retrieval in these particular units. We learned a few other things. So we looked at the data and says, when do these patients die? So we looked at the 7 days and say, what actually happens? So there are patients who die within the first 24 hours. And we think this is because of neurological deterioration of the actual stroke itself. And then we do our things, neuroresuscitation and prevention of stroke extension, and that figure drops to about 8%. But from about day 3, you see more patients dying again, and we think we are beginning to get medical complications at this stage, and some of these patients are now getting the middle cerebral artery malignant, space-occupying edema, and so we're losing more patients. But that sort of tails off by 7 days. So if you look at those first 4 days, if you can actually intervene in those first 4 days, you could actually do a lot to reduce the case fatality rate at 1 week. Now, that slide, ignore everything else except for that figure in red. That's what I want you to concentrate on. So we looked at our quarterly mortality and say, how many patients are we losing per quarter? And in that last column, it was anything between 4 and 7 for that time. But if you look at that time there, we lost 27 patients between May and August of 2014. And we wondered what has actually happened. How did we suddenly go to losing 27 patients? And what had happened is that young lady in green, the sister in charge, she broke her leg. I don't know what she was doing, and she had to take 3 months off. So she went off. And we looked at every other metric and says, the neurology, the stroke doctors were there, the rehab team was there, and our stroke mortality went. And when she came back, you see the number dropping to 4 and 7. And we think that one of the most important person in a resource-constrained environment is, in fact, a champion, a nurse who has got training in stroke. That's what this lady has actually received. She did multiple ward rounds during the day. She taught the interns on the do's and don'ts, and she made sure that they stuck to the stroke protocol. There was no deviation. So that was a key lesson for us. Now, subsequently, there were other grants that we got, and we always made sure that we would also try and put stroke in there. So there was the Partnership in Education Research Advancement Grant, which Professor James Akim was part of. He was the PI for that. And one of these things, what they wanted to do was to introduce collaborative practice and interprofessional education. And we said, well, that's what we do on the stroke unit. So we can learn the stroke unit because that's what we work as a team. We've got our nurses, our rehabilitation teams, and the stroke doctors. So we actually became part of the Petra as a demonstration project of how interprofessional education and collaborative practice improves outcomes in our patients. Now, that's a map of Zimbabwe, and each of those little blue areas, those are the stroke units that we subsequently managed to set up. So I was privileged to be the lead in setting up the stroke units. So the first one is the Harare one, the 12th November 2013, which has up to now admitted more than 4,000 patients. And we went down to the Midlands State University, which is another university that we're working with under Petra, and we opened a stroke unit on the 9th of March 2021. So far, they've admitted 456 patients into their stroke unit as of last week on Tuesday. We went to the National University of Science and Technology in Bulawayo, which is the biggest, second biggest city in the country in southwestern Zimbabwe, set up another stroke unit on the 10th of March 2021. And so far, they've admitted about 280 patients. It's one of the smaller stroke units that we have set up. We then went east of the country on the 18th of January 2023 and set up the Victoria Chitepo General Hospital stroke unit in Mutare. That's my hometown. And up to date, they've admitted 310 patients. Now, the people who run these stroke units, the doctors, they've all worked in the Harare stroke units. They are the MMeds. Some of them have been to Denver, and they now run these particular stroke units. Now, one of the things that you realize is that there are very few of us, and we're not going to be able to set up stroke units in every hospital. So what we decided to do was to develop a stroke app. That was Professor Matenga, a young lady called Miriro, who is an IT specialist, to set up a stroke app that is nurse-led. So it's actually meant for nurse-led stroke units. And it comes from that 27, where we realize that perhaps he or she is one of the most important parts of a stroke team. And a lot of the district hospitals in Zimbabwe, some of them don't have medical doctors, or if they're medical doctors, they've got multiple roles. You are the medical superintendent, you are the obstetrician, pediatrician, surgeon, and stroke specialist. So we did develop this app that we are still piloting. And we wanted to standardize stroke care in Zimbabwe using this app that will help them to manage stroke, to access stroke care clinical concepts, and aid decision-making. It's a really interactive tool. If you put the blood pressure, it tells you exactly what to do for that particular patient. It allows our nurses to make decisions. It feeds back this information to the backend, so we're able to review this information. And if stroke mortality goes up in a particular hospital, that's a red flag. We can phone them, we can go there, we can retrain. So it's still being piloted in the stroke units that we have actually set up. There have been some scholarly output from the Parirenyatwa stroke unit. There's a publication on urinary tract infections in patients admitted by one of the fellows. And then there was another study on warfarin pharmacogenetics that was on that particular stroke unit. But the third one, I was really proud to be part of that, where we contributed to the Global Stroke Registry that looked at the global impact of COVID-19 on stroke care and interventions, and particularly thrombolysis, which was published in the Journal of Neurology. Now, we've had challenges. So stroke units were closed at the height of the HIV pandemic, and you can imagine they needed space. So for 2 or 3 years, our stroke unit was shut down because they needed the beds. And the problem is that we lost the momentum, and some of the members of staff migrated to other areas. We also have limited internet access in some of the hospitals for that app. You can use it offline, but you need to go back online so that you can basically upload some of this information so that we can look at it. And we don't always have reliable, neuroimaging services across these 4 stroke units across the country. They all have access to CT scans, but at times the equipment is, not functioning. And post-discharge, we don't have adequate institutional and outpatient rehabilitation facilities. And so one of our residents looked at the outcomes at 3 months and realized that, in fact, the mortality seems to be going up again because we're missing this particular aspect. So in conclusion, we need, across the sub-Saharan and every other resource-constrained facility, in the meantime, we need to adopt stroke units as models of care. And in their simplest form, as I've said, you just need to reorganize the existing hospital beds into a well-defined area that you call a stroke area or stroke unit. And they often require very little funding or very little extra funding. And they're specific endpoints. So it doesn't actually become a dumping ground for patients with strokes, but in fact leads to organized discharge of patients because there are specific endpoints. And expertise increases, and as you have seen, as expertise increases, you tend to get better outcomes. And these minimal cost stroke units are very effective at improving stroke outcomes, as you have seen, and countries in sub-Saharan Africa should ramp up the setting up of low-cost stroke care units to improve stroke outcomes. And I've repeated this again, that it's feasible to set them up. So we should not be intimidated. We shouldn't worry about trying to set up what you guys have here at UC Denver, because at the moment we can't. And they benefit from a multidisciplinary care, and they reduce mortality, they lead to improved functional outcomes. Collaboration is important. As you realize, we collaborated in country with the other universities. We collaborated with Stanford, UC Denver, the University of Cape Town, and that was really, really useful. And that probably brings me to the end of my presentation. And I would like to thank and acknowledge everyone here at UC Denver, including your chair, Professor Chopra, colleagues at UC Denver, for asking me to come over and share our experiences, the Grand Round Selection Committee that gave me the privilege of presenting the inaugural, James Hakim Grand Round, and the collaborating universities from Zimbabwe, the Midland State University, Africa University, the National University of Science and Technology, and of course, my own university, the University of Zimbabwe. I thank you.
Professor, what a lovely talk. And just a reminder both of how privileged we are here, but also how you can make these things work in countries with limited resources. So a true testament to your dedication and commitment to those patients. Maybe I'll ask the first question. And I was surprised to see when you looked at mortality over time, that there seems to be sort of this bimodal distribution. There seems to be early death and then maybe death later in time. What I was trying to understand was, what is time zero? Time zero is when they come to the hospital. Have you seen, or are there efforts now in the pre-hospital stage before they can even come to you? I'm thinking about public health awareness, campaigns about stroke, ways to get people into the hospital earlier so perhaps they could have a better outcome.
Thank you, Prof, for that question. So at the beginning of the stroke unit, we did not do that because we're trying to refine the unit. So we didn't want to be inundated with 100 patients with an 8-bedded stroke unit. So initially we didn't do that. But once we got a bit more confident, that's when we got the Ministry of Health involved. And we are now trying to educate the communities that presenting to hospital early is important. It's amazing how people think that there's nothing that you can do for stroke patients. So, and at times that goes, health workers think similar, that there's very little that you can go into do. You're going to be admitted, get physiotherapy, and that's it. And good luck if you get better, tough luck if you don't. And so we are trying to do that, but we don't have a very good pre-hospital service. I mean, I saw one here. I managed to see one of your mobile stroke ambulances, amazing vehicle. And we are trying to get to that particular stage where we can educate communities that if you present early to hospital, there are things that we can do. We may not be able to do the fancy things that are offered elsewhere, but we can do something that can reduce your risk of dying, especially within the first week, and that could possibly improve your functional outcomes.
Thank you so much. Dr. Hagen.
Thank you very much. That was wonderful. My question was basically Dr. Chopra's question, but I had a second part to it. In the idea of, have you first figured out what the barriers are to people coming in late? And then second, if you compare it to something else like myocardial infarction, is that delay still there, or is it unique to stroke?
So thank you very much for that question. So it's not unique to stroke. We seem to have a very different health-seeking behavior in Zimbabwe and pretty much in Africa, that there are a number of other beliefs. So when somebody gets a stroke, we try to ask that question. So, you had a stroke 12 hours ago. What was happening in that period? And some of them will say, well, we thought you'd get better. Okay. And some patients have had transient ischemic attacks and gotten better on their own at home. I say, well, he did this 2 weeks ago and he got better. And then the second thing is there are other medical treatments, traditional healers, faith healers. And in fact, that's where they go initially. and they only come to you because things haven't worked at the traditional healer or the faith healer. Now, the ambulance service, again, isn't great. The paper from Guinea was very instructive that perhaps only 12% of their patients arrived at the hospital using an ambulance service. The vast majority used private vehicles, and they also used public transport. So it's the transport system, the ambulance system, and just different knowledges and attitudes towards stroke. So that's where we need to educate the population that it's a medical condition. They are useful, simple interventions that could actually improve outcomes.
Additional questions? So over there.
Thank you, and thank you for coming to visit us. I'm a gastroenterologist, and so we see a lot of these patients who have complications from their stroke, such as bleeding. So in terms of establishing all of the other infrastructure that you need to care for these patients, so people who have a upper GI bleed because of their anticoagulation or who need feeding tubes, can you speak about the creation of those other supportive disciplines?
Thank you for that question. So we fortunately do have that sort of support. So we do have the GI service, and they assist us a lot in terms of placing pegs. So some of these patients will require pegs because they're unable to swallow, and we do have access to that service. In fact, the guy who runs it is my neighbor, so the negotiations are a bit easier because so I can get that done very quickly. And of course, we have other things. Rehabilitation is very supportive. GI team is on standby. So we do have access to those particular services.
Okay, and then one last question. You said the sister, does that mean nurse?
Yes.
What does that mean?
Oh, so that's the nurse. So for that's a nurse, and she was the nurse in charge. She got a lot of training, and she would actually come over weekends, even if she was off duty. Unfortunately for me, she has been promoted. She's now a nurse tutor at the nursing school. So we have lost her again. She still comes, she still volunteers whenever she gets time, but we have lost her. It's good for her, bad for us.
Hi, thank you so much for giving the talk. Very informative. I spent about a month in Cameroon, and we had similar issues with stroke. People come late. For the partnership that you made, is it possible, how do you set it up in other African countries, like Cameroon or Nigeria or Ghana? I know sometimes there's an issue with like politics and the government, but how's your success rate, and how you recommend setting it up in other places?
Yeah, so one of the things is to share. So we've been sharing with colleagues. There's an African stroke organization. Neurologists are interested in stroke, so we share information. I was recently sharing information with a colleague in Zambia. She has just set up a wonderful stroke unit in Zambia. And there's another in Malawi. 2 years ago, Malawi set up its first stroke unit, which interestingly is actually nurse-led. So it's not led by I think they've got one neurologist in Malawi, as far as I know. So this is actually a nurse-led with support from the neurologists and the internal medicine specialists. So I think if we share information, it's very easy to be intimidated to think it can be done. But if you talk to people who have actually done it, it's not as difficult as we think. We now have the experience, and their colleagues who have got the experience, and should be sharing this information across the African continent. I've got a colleague from Cameroon that I work with on epilepsy, and maybe I need to sit with him and see how we can share our stroke experience.
Gift, it's very great to see how you've replicated the stroke unit at other cities in Zimbabwe. Do you have any outcome data yet in those other sites?
Thank you, Tom. No, we don't have at the moment. We haven't looked at that. It was one of the things that we intend to do this year, and just look whether they've managed to replicate the same thing that we did in Harare. We do have a rough idea of what's going on, but we actually haven't analyzed this data so that we can come up with conclusions. So feedback that information to UC Denver once we get it.
I have a couple questions. Two things. You mentioned, I mean, this is an amazing model, and congratulations and thank you so much. Have you thought about applying this model to other disease states that would benefit from specialized multidisciplinary care? It's question one. And question two, you mentioned a couple of times during your presentation, even though this was done without additional funds, you mentioned, for example, PEPFAR funded cardiology and so on. What's been the impact of the PEPFAR changes on non-HIV care like this?
So thank you. So I'll touch on the impact first. So the impact has been huge, and not just for stroke, because when that program came on, we didn't actually have a lot of subspecialty training in Zimbabwe. And so we were able to increase our subspecialties. We now have the first 2 interventional cardiologists in Zimbabwe through this program, 2 young, wonderful ladies. Both of them have been to UC Denver, and they now do interventional cardiology and interventional procedures in cardiology in Harare. We've got pulmonologists, we've got nephrologists. So the impact has been huge, not just for neurology and stroke, but right across the disciplines in internal medicine. And we're very grateful for that. And then the second thing is that they're beginning to replicate this as well. So we're beginning to set up units. So in the old days, all patients will be managed by internal medicine in 1 unit. And we're beginning to see, GI units. We get a pulmonology unit. Recently, the 2 young ladies set up a cardiovascular service at our hospital. So this is beginning to be replicated in other areas. And that has been great.
Professor Ngwende, we talked a little bit before your lecture about the diffusion of smartphones and technology in Zimbabwe. I was impressed that you brought up the app as a strategy to sort of teach nurses. Can you talk more about the utilization of that or any data you saw from the app itself?
Thank you very much, Prof, for that question. So Zimbabwe has got a very high penetrance of smartphones for one reason or the other. And the typical Zimbabwean has got 2 smartphones. And the reason is that there are 2 or 3 different networks. And depending on where you are, the reception is not always great. So if this one is not working, always just fish out your other phone and you use that. So most of people have got 2 smartphones. I've got 2 iPhones, actually. And so the penetration is there about 14 million smartphones in Zimbabwe. And this is a population of 16 million. You walk into an average village in Zimbabwe, you see an old granny with a smartphone and she's doing her stuff. And we decided we could actually use this technology to deliver healthcare. And when we set up this stroke app that we are trying to use, is realizing that there are not enough people to go around. And we have to try and develop innovations that allows us to deliver care, not just in stroke. I was talking to colleagues about an app that we have developed in epilepsy. And what it is meant to do is to help diagnose epilepsy in the communities where people live. The EEG service is in Harare, and you might have to drive 400, 500 kilometers to get a routine EEG, which is 20 minutes. And then you've traveled 400 kilometers, you need transport money, you need to sleep over in Harare, you need to eat, and that will eventually cost more than the cost of the EEG itself. And there's one program that I'm working with where we have designed, or they're in the process of designing, a new EEG headset that is robust and that can withstand, the harsh environments in the rural areas. And a nurse can put that EEG headset and it can record. That information is relayed to an app that does the analysis. And once it figures out there's an epileptiform focus, it relays that information to a second cloud-based app that selects the appropriate medicine for that country. That particular project involves Brazil, South Africa, Zimbabwe, Kenya, India, and the United Kingdom. And on that particular app, it then allows the nurse to make a decision about the appropriate medication in the village without involvement of a neurologist or an epileptologist. We've also designed, part of a group that designed what is known as the Epilepsy Diagnostic Companion, just 9 questions that gives us a reasonable specificity and sensitivity of somebody having epilepsy. Translated into the local language, it can be used by a village health worker with very little training. And if you ask those questions, yes, no, it gives you the probability that somebody has got epilepsy or not. And then the village health worker can refer that to a higher center that can actually do the work. So we can use technology, we can use smartphones in Africa to deliver healthcare. So we have to be innovative about it.
I find that story very fascinating and truly a sort of an element of thinking about the local infrastructure as you have. We are at time, Professor Ngwende, so thank you once again for your visit. Look forward to seeing more and hearing from you. Thank you.
Thank you very much.